Thanks, Jen. We've now arrived at our third and final panel for the day, leveraging the power of data-driven approaches to improve and sustain the vital conditions. Dr. Bobby Milstein will once again facilitate the discussion.
Thank you, John, and welcome to the third panel in really what has been a fantastic day spotlighting innovative uses of the vital conditions framework. The purpose of this panel is to focus on the interface between vital conditions and data. We're going to hear state-of-the-art examples of folks who really are learning firsthand the power of data and new data platforms to establish vital conditions with a clear focus on equity and racial justice. There's so many things that data can do. It can help us clarify aspirations. It can help us identify assets and opportunity. It can help us negotiate priorities. It can help us chart progress. The sky's the limit, really, when we're committed to being curious about where are we now and what's it going to take to make a great stride forward toward well-being and equity. We're also going to talk about the who is involved with this work. We'll discuss the critical importance of bringing diverse perspectives into this, to do collaborative sense-making, storytelling, case-making, those kinds of things. The data don't always speak for themselves, and we have to bring the points of view together to understand what it means, and particularly what does it mean for the kinds of actions that people are going to take next. I am joined by some of my favorite colleagues in this work, with whom I've learned much of what it takes to do this. We've got Roxanne Medina-Fulcher, Executive Director of the Institute for People, Place, and Possibility. Sequoia Rent, who's the Chief of the Bureau of Health Equity in the state of Delaware. Jasmine Hutchinson, who's Community Benefit Director at Loma Linda Health. Elaine Darling, the co-CEO and Director of Programs at the Center for Rural Health Development. And Jason Schulis, Director of the Fox Valley Data Exchange. All over the map, different pathways into this work, different levels of experience and investment in this. But with the through line that they all have in common is a commitment to not just focus on vital conditions, but to bring the power of data to this work as well. So let's turn to you, Roxanne, first, and maybe if you can just share a little bit about how you're coming to this, the history that's bringing you into focusing on vital conditions, and the kind of data to action cycle that I know is so important to you and your team.
Great. Thanks, Bobby. Good afternoon, everyone. Again, I'm Roxanne, and I'm with the IP3 team. IP3 stands for Institute for People, Place, and Possibility, and we're a nonprofit that's based in Columbia, Missouri. But since the pandemic, we're all over the nation in different parts of the country. And our organization is really working to create healthy, equitable, sustainable communities, and we're stewards of community commons. We do this primarily through curating resources from the field and sharing them broadly through our public good website, communitycommons.org, and also supporting the field with web-based applications like IP3 Assess to simplify data, reporting, and for needs assessments, data sharing, and data-driven action planning. So we started our work about 15 years ago when data for the public use was really hard to access. We had taglines like data democratization or making public data publicly available. And we were privileged to really be a part of the national community improvement efforts that were really sparked by CDC, Robert Wood Johnson, Kaiser, Kellogg, YUSA, and United Ways, all around the Healthy Communities movements. And through that, we were developing and making data accessible primarily for community needs assessments. And we've continued to grow and learn from our partners and have shifted our approach from just accessing data to actionable data. And on this next slide, you'll see some of the key insights over the years. So these are short, but very impactful for our work. For first, put data in its place. What do we mean by that? It's really looking at not just data-driven decisions, in fact, actually moving away from data-driven, but to data-informed decision-making. We learned that there's a need to really ground truth our data in the community and hear from those that will be affected by these decisions that are being made off of the data. In fact, it's even better to have the authentic voice in the decision-making process. Also, there's data or power. We all knew that from the very beginning, but from a health equity lens and data empowering communities, with that knowledge to drive the transformational change. And then putting that data into context is where the data becomes so much more powerful, and the community can get really into and behind the decisions that are being made. We're just wrapping up a project in Detroit. It's a pilot project. I have to stress the pilot, but it's with funding with CDC Foundation, and we're partnering with the University of Michigan and Wayne State University, and it's called Communities in Context. And this is an approach that is very community engaged and gathering and using local data to improve health. This project really centers in on getting community members' voices, experiences, and perspectives on the data for key decision making, and really considers that broad factors that influence health. The last bullet point that I have on here, and these are not the only learnings that we've learned over the years, but these were the biggest ones and the most relevant to the work that the panel today. But catalytic community change stems from the understanding and the shared vision for the future. So actionable data in bridging frameworks like the vital conditions is key to change the conversation and make the data consumable. We have a phrase sometimes that we use, it's called the art and science of either measuring and data. So what we mean by the art is really that measurement, which includes strategies for engaging underheard voices, valuing the narrative, reaching agreement on meaning and priority with diverse stakeholders and perspectives. And then that science is that measurement, which would include really being open to new frameworks like the vital conditions, measuring well-being through self-report data on thriving, with more localized data to augment all of these frameworks. And we see real value in the vital conditions. So in the next couple of slides, this is how our work and tools really reflect these insights. As I shared earlier, the community assessments is where we started, whether it was a hospital system, public health department, community action agency, whatever. It was what's the data, so what, interpreting and ground truthing that data, and then community engagement, and then to now what, the actions that can be taken and what learnings can be lifted up. The other bubbles around here, you might really be familiar with the community assessment and progress tracking and prioritization. Those might be very familiar, but building the shared language, using reports, engaging the community, all those things are important and are built into the way that we work. And the next slide, we really hope that the data goes beyond the assessment phase. So what is that advocacy and case making? What are the coalitions and networks and data visualizations and ways to use this information beyond the assessment process and to really keep the community informed? If you go to the next slide, which is really showing and highlighting, and since this isn't a live demo, I had to take some screenshots, but at the heart of what we do and the heart of our tool are really the frameworks, with the vital conditions framework being at the core framework, a core framework. What this means to us is that because frameworks are really key to analyzing and presenting data in digestible ways, this means this core framework is available to anybody that we work with out of the box. Now, often we change the data to make it more local or add if there's well-being data that's being collected, but at the heart of it, the vital conditions are central. Our tool will analyze from different sources using Z-score analysis, and so we're comparing apples to apples within each domain so they can be rolled up to C1 score. So you're looking at 7 domains right here, and you're seeing the red and the green, and just know that behind that, and if we were live, we could unpack it, but there are over 75 plus indicators that are hidden behind each one of those. I mean, not each one, but throughout that entire framework screen. The other thing that I wanted to point out is really on the top right, there is a drop down, and one of the other key components with the way that we work is to be able to flip quickly and seamlessly between different frameworks. So we know vital conditions, as great as it is, isn't the only framework out there, nor is it the only framework that will resonate with the audiences. So we try to make it as easy as possible. On the following slide, We have again, very tiny, quick snapshots, but you can see that we unpack the data. This is just showing some of the ways that we have broken out the data. And then on the right, you can even go deeper, see trends. And then down at the very bottom, you'll see how it's connected to the community commons. The next slide, and again, just trying to go through this very quickly, is reporting. And we're unable to show you a report here, but we have a list of reports that you can dive in. And these are ways that our partners have packaged this data, very relevant for their audiences, and being able to really take a look at the data in context with resources. The last slide that I have on here is the community commons. You can go there and explore over, I think we're up to 14,000 different resources categorized with priority populations, with many different ways of segmenting out to find what's happening in the field. And we will be providing you with a lot of different links that you can come and explore this, but thank you so much for your time.
Thank you, Roxanne. That was a terrific tour through more than a decade of learning about what this work takes. And it's a perfect segue to Sequoia Rent next, one of your colleagues who's been doing this on a statewide scale, which is itself impressive to do this not just in a particular community, but to have all the cast of characters across Delaware begin to focus on what are they assessing, and more importantly, where are they placing their priorities for improvement in the years ahead. So Sequoia, can you tell us a little bit about what your work is doing these days?
Good afternoon. My name is Sequoia Rent, and as Bobby said, I am the Chief of the Bureau of Health Equity at the Delaware Division of Public Health in Delaware, and I'm thankful for being here this afternoon. And I'm going to discuss how we link the vital conditions and data in what we're doing. So the Bureau of Health Equity within the Delaware Division of Public Health aims to eliminate health disparities related to the social determinants or influences of health and the vital conditions for health and well-being in health outcomes. We work in tandem with our internal division partners, sister Delaware Health and Social Services agencies, cousin state agencies, and external partners around the interconnectedness of our related work to multi-solve for Delawareans. Multi-solving is intentionally considering the impacts and gaps of a solution and then working to find solutions to address those as a part of the solution, usually across the vital condition areas and sectors. Our priorities are to intentionally multi-solve and, as I mentioned, to leverage resources and to align efforts so we can maximize our collective impact. As our work relates to the vital conditions and data, we uniquely oversee our state's state health assessment, we call it the SHA, and state health improvement plan, the SHIP. These documents help us track our efforts, not just within our division, but our state as a whole, on our top health indicators and health outcomes, as defined by the data and the voices of Delawareans. Our SHA is a statewide assessment that used the vital conditions of health and well-being framework to shape and align our primary data collection and tracking. We then spoke directly to residents using the vital conditions to shape and frame those conversations. Then we scanned the existing data, the community health needs assessments of our hospitals, and our legislation, and our partnership coalition, and educated and coalesced around the vital conditions, the members of our coalition, and determined our state's top health priorities. All of that informed the creation of our state health improvement plan, the SHIP that I mentioned. Although in previous SHIPs, we did not track our data using the vital conditions framework, we can cross-reference indicators as we move forward, and we can apply the framework in almost any initiative, project, and multi-solve to address it. For instance, we are working with a cross-sector group to end involuntary youth homelessness in Delaware. We, as in Bureau of Health Equity, are a part of this effort because humane housing is a vital condition area linked to health outcomes and a person's well-being, including cardiovascular health, are linked. And article published by the American Heart Association Council on Epidemiology and Prevention outlined research findings strongly linking housing and what the article called pathways for people to cardiovascular health outcomes. People experiencing homelessness, home insecurity, and housing with poor quality and safety to vital condition area components of the thriving natural world and belonging in civic muscle were evidenced in the research, referenced as social determinants of health. It reported the data suggests that compared to the general population, adults experiencing homelessness experience 60 to 70% higher rates of cardiovascular events. Since in Delaware, disparities exist for people experiencing homelessness, the vital conditions offer a framework for us to track that data and work collaboratively across agencies and sectors to tackle upstream causes, both traditional and non-traditional, before they become those prevalences. A 2019 fact sheet from the National Healthcare for the Homeless Council and the National Network to End Family Homelessness stated that youth who've experienced homelessness have a higher likelihood to have higher adverse childhood experience scores, which evidence suggests people with 4 or more ACEs are 2 to 5 times more likely to develop a chronic health condition such as a cardiovascular condition compared to people with no ACEs. Within the framework, we can track data for access to care, access to healthy food, and reliable transportation to said care and food, among other risk factors. Tracking data here can also show if there is no link for some subpopulations, which is also important for us to know. But it doesn't stop there. Our partners are increasing their education, awareness, and use of the vital conditions internally and externally. Internally, the Bureau of Health Equity is integrating the vital conditions framework into our evaluations with partners and our contractors and vendors, encouraging them to build their subject matter expertise and cross-sector alignment. This will increase our data and tracking using the framework. New team members to the Bureau are being educated in the vital conditions and multi-solving as they are onboarded. With ongoing education, its use in multi-solving will become second nature as we look at data trends over time. We are creating a Delaware Health Equity report, integrating the vital conditions framework with another framework and showing how the vital conditions are an evolution of the social determinants or influences of health through the linkages and data-driven action. We introduced the vital conditions to our legislators and integrated them into legislation codifying the Bureau of Health Equity, Office of Minority Health, and Office of Women's Health. We are also spreading this wealth and it's gaining traction in our state. The Delaware anchor hospitals are increasing their awareness of and discussing the vital conditions as they prepare their next round of community health needs assessments. And as a result of our Health Equity Summit last April, more people and organizations are incorporating the framework and multi-solving into their programs and organizations. Delaware kicked off its Cardiovascular Learning Collaborative on October 10th, working to improve the quality of life through the prevention and control of CV and its risk factors. Through 3 work groups, the awareness, availability, and coverage and equity, you could guess which one I'm a member of, and using data, the vital conditions, and the community voice to drive action, this new collaborative will move forward in accomplishing its goals. You can see them there. Advancing health equity and prevention, treatment, and management of CV disease, optimizing health through prevention of chronic diseases, improving response to acute cardiovascular incidents, and support cardiovascular disease management. It was very timely. As a reminder, October is Health Literacy Month, and that is applicable to providers and anyone else who is creating or shaping health materials. I want to thank you again for inviting me, and my information is on the screen. Please feel free to reach out and ask any questions you may have.
Thank you so much, Sequoia. I can't resist asking one quick question, which is, how long have you been working on the vital conditions thing? Like, has this been decades or like how fast have you done this?
Not decades at all. I would say about 2 years.
Oh, incredible. Just the speed at which where you started with the commitment to look at data differently and the degree to which it's become institutionalized. And I love what you said about it being routine and second nature for people to start thinking and acting differently. Lovely. So let's go to the other side of the country, to California. We've got Jasmine to tell us a little bit about what's happening within Loma Linda Health.
Hi, everyone. It's a pleasure to be here with you all today. My name is Jasmine Hutchinson, and I'm the Community Benefit Director for Loma Linda University Health. The Vital Conditions Framework has really been a game changer for us. It's opened our eyes to the interconnectedness of our efforts, inspiring us to dream bigger and act bolder. When it came to data, we started by asking ourselves some tough questions. How are we truly helping our communities thrive? Which of the vital conditions are we addressing and not addressing? How do our policies and programs impact those who are suffering and struggling the most? This honest reflection showed us where we could do more and be better. When it came to our vital conditions journey, we first identified opportunities to integrate the vital conditions into our existing work. The most prominent areas were our community health needs assessment, conducted every 3 years, our grant-making process, which invests in local community-based organizations, and our annual report, our primary communication tool for showcasing our impact. Next, we analyzed our current programs and investments to see how they align with the Vital Conditions Framework. After that, we conducted a thorough review of national data sources. The data and measurement resources from IP3 Assess and Community Commons that Roxanne mentioned were an amazing starting point for us as well. It's also crucial to consider the unique local context by examining significant geographic and disparity trends and supplementing with local data and what you have available. So ask yourselves, what are the greatest threats and opportunities in our community and for the populations we serve? For example, in the Inland Empire, California, we have one of the fastest growing populations in the country, making it increasingly difficult for residents to afford housing and access health services. Additionally, the rapid growth of the warehousing and logistics industry in our region is exacerbating what is already one of the worst air quality situations in the country, disproportionately affecting our most vulnerable populations. Applying the Vital Conditions Framework has helped us to identify multi-solvers, those programs or investments that yield benefits across multiple areas. It's also revealed gaps and blind spots that we needed to address while strengthening our cross-sector collaboration by creating this shared language and understanding. So what did we learn from our data journey? First, we acknowledge the need to ask new questions. Our research and data collection tools now focus on all vital conditions and aim to measure the levels of thriving, struggling, and suffering in our community for the first time. Additionally, we've included all sorts of questions to explore barriers to meaningful work and wealth, lifelong learning, and to really assess feelings of belonging as well. Our data journey has helped us identify our multi-solver programs that address multiple vital conditions simultaneously. For example, our Diversity Healthcare Pathways program strengthens several of these conditions all at once. Our grant-making data revealed to us that we had been prioritizing investments in urgent services over the vital conditions. The issue is that we just can't simply provide urgent services to achieve thriving communities. When vital conditions are denied or disrupted, people struggle and suffer, increasing the demand for urgent services and creating this downward spiral. So, we revamped our grant-making criteria to align with the vital conditions. Now, grant applicants must show us how their funding requests will actually strengthen the vital conditions. This subtle shift helps us to prioritize investments that drive real transformative community change. It's also helped us to identify investments that are the biggest multi-solvers. The framework has also been really helpful in identifying where our organization was actually causing harm to the vital conditions. For us, those fell into two primary areas. The first was environmental impact. as a large academic health system, we recognize the need to do more right now to reduce our impact and build resilience to climate change. So we teamed up with leaders from across our hospital and university system to launch a coordinated effort that aims to engage every one of our more than 20,000 employees, students, and faculty to do their part. The second area we focused on was medical debt. Medical debt is a widespread issue affecting 38% of Californians. Patients with medical debt are far more likely to be unstably housed, food insecure, and to delay or forego necessary healthcare and prescriptions than those without medical debt. Medical debt also disproportionately impacts people of color, low-income residents, families with children, and people with chronic health conditions. We decided to tackle this issue in two ways. The first is we launched an internal task force to figure out how we can make it easier for patients to access financial assistance within our own system. The second thing we did was to team up with a national nonprofit and trusted community health workers to launch an innovative program to eliminate medical debt throughout our Inland Empire region of California. With our effort, we're trying to make it easier for low and middle income patients to access the financial assistance programs they're eligible for at more than 50 hospitals in our region. On average, a family of four earning less than $125,000 will qualify. By eliminating medical debt, we're not just offering relief, we're paving the way for a healthier, more financially secure and better secure community and better access to healthcare. You can learn more about that program at dollar4.org/LSOL. So how can you integrate vital conditions into your reporting? Along with incorporating new data sources, we decided to use icons to help readers understand how each of our programs and partner investments aligns with the vital conditions framework. Visually integrating the vital conditions has proven to be a powerful tool for communicating our story and connecting our story to the work of others in our region. One of the things that's been most amazing about the vital conditions is how it can create new synergies and cross-sector collaboration. We're lucky enough to have a growing regional network that's allowed us to make new partnerships and align our work around the same North Star. The ultimate goal of our work together is all people and places thriving, no exceptions. Thank you.
Jasmine, you were not kidding about dreaming bigger and acting more boldly. What an impressive story. That again, the through line here is beneath the data is a kind of passion to be able to work differently, to be able to pursue multiple goals at once and to look for those multi-solvers that make sure that they're going to connect. Lovely. So let's go to Elaine in West Virginia. And one of the nice things that we're also hearing throughout all these talks is the ways in which this is not a disease body part population framework. It's a way to look at people in place. And I'm wondering how you and your colleagues in West Virginia have been using this to take a fresh look at what's possible in West Virginia.
Good afternoon. Thank you for inviting me to be part of this panel. I'm delighted to be here with you today. As Bobby mentioned, I'm with the Center for Rural Health Development, which is a nonprofit organization located in Putnam County, West Virginia, but that serves the entire state. We have a twofold mission to improve the health of West Virginians and to strengthen West Virginia's healthcare delivery system, especially in rural and underserved communities. We have several programs at the Center for Rural Health Development that focus on one or the other aspect of our mission. The program that I'm going to talk with you about today is our newest program, Wild, Wonderful, and Healthy West Virginia. We developed this program in 2017, 2018 because we were looking at America's health rankings and noticed that West Virginia has been in the bottom 10 of all the states every year since 1990. Sometimes we bounce around a bit within that bottom 10, but we've never made it out of the bottom 10. And although we have strong programs at the Center for Rural Health Development, we felt that we needed to develop a new program that targeted the root causes of many of our health issues throughout the state. So we developed Wild, Wonderful, and Healthy West Virginia to provide support for local collaborative partnerships to develop community health improvement plans that create long-term sustainable changes to improve the overall health of communities and promote economic prosperity. This is a snapshot of the community health improvement planning process that we use. We begin the process with visioning and stakeholder engagement. In that phase, we work with communities to define what their communities are. Some decide to focus on an entire county, others focus on a city or town, and some community teams focus on a neighborhood. But it's up to them to make their decision on what is truly the community that they're focusing their community health improvement planning work on. At the same time, we work to develop cross-sector community teams, and I'll speak in a little bit more depth about that in just a moment. Those teams then conduct the community health needs assessment, and as part of this phase, they begin utilizing the vital conditions framework to consider the health and well-being of their communities, and they look at the data within each of those conditions. They also use this time to conduct community listening sessions, surveys, and or community forums to gather additional information about the health issues within the community and to inform the development of the community health improvement plan. The Community Health Improvement Plan is a 3 to 5 year plan that describes the community's goals and strategies, including policy, systems, and environmental changes, to improve the vital conditions within their community. Once they've developed their Community Health Improvement Plan, they develop action plans, which are a 12 to 18-month plan of the steps that they'll take over the next year in order to work towards meeting those long-term goals identified in their CHIP. I previously mentioned the development of cross-sector teams at the start of the community health improvement planning process. This is an illustration of the sectors that are typically represented in these cross-sector community health improvement teams. While hospitals and health departments, et cetera, typically conduct community health needs assessments and community health improvement plans, it's vital that to achieve the most success in advancing the goals within the subsequent CHIPs, that a variety of sectors are engaged in the community health needs assessment and the community health improvement planning process. One group that I would especially like to highlight and emphasize the importance of engagement with are individuals with lived experience. They have unique experience, expertise, and in-depth knowledge about the specific health issue being faced. And so we feel it's vital for them to be engaged throughout the entire process. While we work with the community teams to conduct community health needs assessments and then develop the community health improvement plan, we begin pulling data from a dashboard that was created for us by IP3 Assess, which breaks out the health and well-being data by vital condition. Here you can see a screenshot from our website, but each of those vital conditions then break down further into subsequent data related to each condition. They've also provided data for all of the counties in West Virginia and for the communities that have requested it, including some neighborhood data and city or town data. So this has been a very helpful resource for us as a starting point for developing the community health needs assessment. We frequently augment and pull in additional data depending on the vital condition that the community wants to focus on. And then again, we typically use community surveys, interviews, listening sessions, and or community forums to augment this information and to be able to use it to inform the development of the community health improvement plan. We are currently working with 8 communities throughout West Virginia through our Wild, Wonderful, and Healthy West Virginia program. Most of these communities have been engaged in this program for several years, although we do have one community that just began this program. Here you can see the vital conditions that each of the communities are focusing on. So some focus on safe and affordable housing, others focus on meaningful work and wealth, and some focus on basic needs. Some focus on more than one vital condition as well. And typically they'll start with one vital condition, and then when they begin to develop a new CHIP, they'll expand and bring in another vital condition to focus on as well. Some of these communities have been engaged for several years and are now on their second community health improvement plan. As they work to develop their next community health improvement plan, they review the vital condition data to evaluate their progress to date and then develop their next CHIP and action plans. Thank you.
Marvelous. Thank you so much, Elaine. I'm just so struck by the idea of the learning journey into this work. The starting places, it's hard to predict where it's going to go when you start getting into it. And the statewide coverage that you're describing is really thrilling. So let's turn to Jason Schulist. I've been to the Fox Valley. I've seen the energy of hundreds of contributors there. And there is something new under the sun in Fox Valley, right? The formation of a place-based wide-angle data exchange that many players across the region are now committed to the idea of data exchange. And as I understand, the vital conditions figures prominently in that. So can you tell us a little bit about that work?
Yes, I'm excited, and thank you, Bobby, for inviting us to share some of our work. We are humbled that we are part of this amazing group that I just heard about right before me. I'm stunned by all the great work that's going on. So when we started our work, the seeds of the Fox Valley Data Exchange really began with something called Imagine Fox Cities. And what this was a shared visioning project for 19 cities and towns in our local community up here in northeast Wisconsin. As part of the process, what we did is we convened our 88 community conversations in our community and administered a well-being survey, kind of very similar to the happiness report, the Cantrell ladder that Jasmine talked about at Loma Linda. And really, we did this to determine how the Fox Cities community was thriving, struggling, and suffering. As a side note, if you look at the Imagine Fox Cities website here, you can see on this page that one of the opportunities that emerged was belonging, and that popped up both in our qualitative and our quantitative analysis. So while we collected this data both in 2019 and 2021 as primary data, you can kind of see the amount of surveys that we got out of our 250,000 person community at the time. We noticed that we didn't really have an easy way to understand the overall data in our community. So we decided to canvass the Tri-County area, of which this Fox Cities, so we call it the Fox Valley, how we could look at the Tri-County area and learn what data needs really our community had. And we found a few things. One, it was really hard to find data. You could scrounge around and look for it. If you're doing one of these chip or chop plans, you might hire somebody to go and find the data in various data sources. So we wanted to kind of clean that up and make it easy. We also found that there were many ways to measure the same thing. So we thought if we could improve alignment and get everybody together, we could kind of choose the metrics and the way to measure those metrics so that we have a consistent narrative across our community. We also expanded beyond the 19 Fox Cities to this entire Tri-County region. So we went from about 250,000 people to about 400,000 people. And we wanted to improve our well-being from our past learning. So we could see our thriving, our struggling, and our suffering scores. We wanted to get better. And we knew that using the vital condition framework and using that mindset can really help us versus using a deficit mindset. So that really led to the creation of a nonprofit, the Fox Valley Data Exchange. We wanted to make it a nonprofit so that it was agnostic to any one funder. We had previously done some work in this area through our community foundation and our United Way, but we wanted to make sure that we were much more integrative. And so we wanted to make our data easy to find and transparent for the community. So this totally free resource, and you can go out at vitaldata.fvdex.org and check it out anytime you want. It helps our 7 stakeholder groups. So we have nonprofits, foundations, business, healthcare, public health, education, and faith communities that are working together across these 3 counties to make data-informed decisions on where they can invest in the vital conditions. We use the vital conditions framework as our framework to think through the work. We do that because we want to shift the mental models within our community, move from deficit thinking to kind of a growth thinking. And similar to our Delaware friends, enables our stakeholders to work together cross-sector and across the vital conditions so that we can multi-solve our biggest issues. This is just an example of our easy and accessible data platform. So as you can see on the left-hand side, we break our data down along the vital conditions, and we look at this data geographically. Now, heart disease mortality may not be on the high on the vital condition framework. It's something that's a little bit more on the lagging indicator side. But with one click, I can move from a geographic base to a trend chart of any of the 100 plus data points that we have to help describe our vital conditions. So our 7 stakeholder groups across the 3 counties are really working together to determine what to put under each vital condition. And as we go through that dialogue, we start seeing us working upstream versus downstream in the things that we are measuring. Thanks to the IP3 group that does a really great job curating a set of metrics around the vital conditions. Finally, to determine what we're measuring, we're also integrating local data sources into our website. So we have things like 211 data or mental health primary survey data or our youth behavioral risk survey. All of these are planned for integration into the site so people will have easy accessibility to look at those problems that they want to work on. So our current Tri-County region is coming together to create a unified CHNA CHIP plan between public health and healthcare, kind of similar to how West Virginia is engaging in their state kind of with the vital conditions. So we're using the vital conditions framework to help really create that community health needs assessment process, and then also how we invest in our community health improvement plan. The Fox Valley Data Exchange has been working alongside this effort to really assist in providing and maintaining data for the community. Many times we'd have that plan, and then there might be every year or so there might be an update, there might not be. We have 7 of those plans right now, so we're going to try to get down to 1, and we'll be able to keep that data refreshed so people can use it and see how we're making progress in our community. We also plan to kick off an annual well-being survey starting in 2025 for our Tri-County area so that we can keep a pulse on our well-being and really ensure that the stewardship and the effective resource allocation along our vital conditions happens continuously as we continue to grow and evolve. So I appreciate the time that we've been given, and thank you very much for listening to how we're progressing.
Thank you, Jason, and thank you all for, in a very short amount of time, giving us a really rich portrait of what this work looks like. I've heard so many similarities and some differences in terms of how you're situating this into your place, into the organizations that are most passionate about this. And that's maybe one place that we can go in our discussion now is a little bit more sort of personal stories about what have you seen about the people who are drawn into this work, the kinds of like openings or invitation that they're experiencing when you're starting to maybe flip the script on what a conventional analysis or a conventional data report looks like. You're all innovating off of a form that has become commonplace. So I'm wondering if you can share stories about the people who are drawn into this and what kind of energy they're experiencing when you start talking about vital conditions, when you start talking about, the people and the places that we love and what it takes to unlock their full potential. So we could do this in any order. If any of you have a story in mind, or, maybe we'll go back to Sequoia, because that photo of the team coming together and institutionalizing, something that didn't exist before, but behind the scenes is a different way of working. So can you share just a little bit about what the energy in that room was like? And I'll leave it at that.
Sure. So coming up to that, we had several discussions, right, about the language in that particular bill. And it started out with the more, social determinants, influence of health. And we had to, talk about what the vital conditions were, how they were in evolution, why we wanted to talk about the interconnectedness of the vital conditions, what they meant for the community, how they were less individualistic, and how they work together. And there were iterations of that bill, and that's why I wanted to share it, because it's kind of monumental, right? The Bureau of Health Equity in Delaware has existed for more than 10 years, but now it's in law, like we exist. in law, and the vital conditions are a part of that bill. And it not only codified the Bureau of Health Equity, but also the Office of Minority Health, which has also existed for quite some time here, and the Office of Women's Health, which had existed, but is now, I think, all three exist. And we have movement there and raised awareness about the vital conditions. And even though it existed there were people in the room, some other legislators, and our governor, obviously, in that picture, who are learning and coming together because aligning a message across the state about how we do our work, not just at state agencies, but in the community, how we track our data, how we look at trends over time, how we thrive, how we build Delaware together as a community is important. And the vital conditions are helping us do that. The framework.
Love it. Love it. I'm wondering about others here. Sequoia mentioned a thing here that, there's comfort in the conversation about social determinants now. And so there can be some reluctance to change the vocabulary. There has to be good reasons for that. And I'm seeing some heads nod on that one. How have you gone through the sort of inertia or growing pains about introducing a different vocabulary with people who might be very eager to stick to the script? I'm seeing Jasmine. You're nodding on that one. What does that look like for you guys?
Yeah, I think especially I think about the hospital context, and there's so many folks who really wrap their minds around the social determinants of health, and it's been such a big part of the script for a while now. There's still a place for the social determinants of health, especially in healthcare. We are now, really at the individual level. We do need to know if folks are kind of falling behind and they need a hand up and what that looks like, right? So our hospitals, all the hospitals now across the country are required to be measuring that. So on the individual basis. But with that, I would say, I have presented at a number of different, about the vital conditions in a number of different spaces, our health equity task force, social determinants of health task force, all these different groups. And I think folks also see that it helps to bring other sectors together. And that's the most exciting thing, I think, for me, because we actually went through a whole process of redoing our vision statement a few years back, and realizing, one of the things I realized was how many different groups out there in our region had the word thriving or some synonym of thriving in their vision statement, and just realizing, like, we're all aligned on this. And so being able to recognize that our partners in the education system and in the housing authority and all these different places, like, we really just all want the same thing. I think that's really important. And especially, in the world of health, I have very often found myself just only surrounded by people working on health, right? And it's pretty common, I think, to be in your own silo. And so what the vital conditions does is it helps us be able to have those conversations with other sectors and recognize that we're all working towards the same, thriving communities.
That's lovely. It makes well, we'll go to Jason one second, but it makes me curious about Elaine. I'm so intrigued by the way you've titled Wild, Wonderful, Healthy West Virginia. Is that serving as an attractor for very different people to show up and say, what's my part in this?
Yes, so Wild, Wonderful, and Healthy West Virginia is actually taken from our state's tagline that we had for a number of years, which was just Wild and Wonderful West Virginia. And so we added the and healthy part to it because we wanted to speak it into existence. We want that to be our future. And so that's how we came up with the name Wild, Wonderful, and Healthy West Virginia. And we've worked with the communities to do a lot of branding specific to make Wild, Wonderful, and Healthy Logan County or Clay County or what have you. And so that they're using that same message and speaking it into existence within their communities as well. But I also want to go back to your previous question on the vital conditions and that switch from social determinants of health to vital conditions. I think that change in terminology, I think, has been very helpful for engaging folks that are not in healthcare and public health in this work. And I think for those who are working in healthcare and public health, it helps them to understand that this is not exactly the same work that they're doing when they're measuring social determinants of health within their patient population. So I think it's really been a way to strengthen the engagement through both of those groups, the healthcare public health groups and the non-healthcare public health sectors as well.
Love it. And Jason, I'm guessing, you laid out quite an array of stakeholders to the data exchange. But what's on your mind here?
Yeah, when you think of some of this work, sometimes you start to think of health, and I know we're at a health conference, so it makes sense too. And it was just an interesting story. So the Habitat for Humanity in our area, they do a thing called Rock the Block. And so Rock the Block pretty much gets a group of volunteers together to go help out in the community, clean up people's outside of their houses, do small repairs, and so on and so forth. But from a multi-solver perspective, it was really interesting because they went onto the data exchange and they looked for different sources of data. So they first went into the usual suspect, humane housing, right? And they looked for people who were severely rent burdened or housing cost burdened to think about where to maybe focus their next Rock the Block. But then they went into meaningful work and wealth, kind of tried to look at a little bit of the poverty side. But ultimately, they landed in the belonging and civic muscle area, looking at the social vulnerability index and looking at seniors living alone. So as they thought about their strategy of cleaning up a neighborhood to make it feel better and look at it outside, they were also thinking about the social connectedness nature of interacting with people in the community. So they were able to pinpoint a specific census tract that they wanted to work in based on using the data in a multi-solver kind of way to get to the point of not only helping from a housing perspective, but then also helping from a belonging and civic muscle perspective.
Sequoia, it looks like you have feelings about that one.
I do. It's what I mentioned earlier. It's the interconnectedness of all of them. And that's one of the things when I talk about the vital conditions that people hear, it's that nothing that we do stands alone. That's why when we talk about eliminating youth homelessness here, we're talking not just about humane housing, we're talking about a thriving natural world, we're talking about their basic needs for health and safety. We're talking about their education, the McKinney-Vento. We're talking about all of it. That's why I think the vital conditions has gained so much traction in the short amount of time that we've been using it.
Yeah. There's another piece of your story, Jason, which is, we've all sort of, sort of acknowledged the aspiration for equity and racial justice, but what does it mean to really identify those that have the most to gain and channel resources first among those so that, we're not sort of casting resources evenly and equitably, even in, consistently, as opposed to identifying those that are poised to make a great stride forward. And that's a little bit of what I heard in your story. It's wonderful. Roxanne, I'm thinking about other kinds of data here, the signals that tell us that, what kind of resources are people looking for. And you have a remarkable asset in looking over the shoulders of those that are using the community commons, this treasure trove of free resources. And are you seeing, and I can't think of any entity in the country that has made so many free resources available and organizing them around vital conditions, organizing them around the questions that that colleagues are curious about. So what are you seeing in trends around what people are looking for in the commons?
Thanks, Bobby. Yes, as I was thinking about all the different stories from the field itself, was trying to think of the times that we were able to maybe be in community. We were out in the Inland Empire. Some of our team was out in the Fox Valley. And so thank you for the entree into what we're seeing from a commons perspective, because I didn't get enough time to really talk about the commons. Some of the things, and one of the things that we have seen quite a bit, and this stems from our early days of being more of a data provider or data access, as I was talking about. So consistently, our maps and data channel is one one that people go to. Either they remember that that's where it's from, or that's what we had most to offer at one point in time. But from that standpoint, we've been able to take that interest in still going to maps and data. And I think that there is a link that I've provided that hopefully it can be used and shared with the audience, but it's the Maps and Data channel on Community Commons. And that's where we're really lifting up all sorts of different either mapping tools or other tools that have been created by others in that channel itself. In addition to that, we've tried to data equity is another key place that people take a look at. And then quite honestly, vital conditions is the other top three that people are searching for on the common. So however the word's getting out there, the appetite is definitely there on the commons itself. And again, I'll try to give the right links so that you can go straight to these components. Or the commons was actually supposed to be a discovery platform. So you might be going there to look for something. So you might be going there to find the mapping tools, but what you'll find within that channel is not just the tools themselves, but all of the wealth of other resources created from the field. And that was one of the things with the commons. You might have to click twice, and that's because we want people to go back to the original source of those tools so that we are increasing the traffic back to the original group that put that either tool, resource, survey, what have you together. So really maps and data, thriving, and equity. Data equity too.
This is another one of those similarities I'm hearing in all of your stories is a closing the distance between a measure, an indicator, and the things that one could do to move it, to change it. So there's so much, it's like really hard to get insight into what other counterparts are doing in other places. And if we could, kind of hold that aspiration that the signals that come through our data systems are really an invitation to a new kind of action. And that's what I'm hearing in much of your work. We only have a few more minutes, and maybe we can end with a round of discussion about what you're wishing for next. You've all set up, sort of a platform to prompt people into new kinds of action. Well, certainly to inform them about, sort of the state of play at the moment, but to prompt people into new action. And if I'm hearing it right, you've set up systems that will detect change over time as well, right? You'll be able to celebrate progress or spotlight those areas that need greater attention that have maybe, being neglected. And so maybe share with us your wish for what you think these data systems, these data platforms can do, let's say, in the decade ahead. And maybe we'll go in reverse order. Jason, why don't we start with you?
Yes, thank you. There's three things that I think about, and I described a little bit briefly before. One is we want to get into a cadence of an annual well-being survey. If we can start to understand how people are doing and whether we're seeing changes in well-being, as well as we do about 14 different questions, including open-ended questions. That gives us a chance to really look from an open-ended perspective where we're seeing some trends. Recently, we did some neurolinguistic programming with our old survey to try to start to find out where and what was bubbling up that wasn't in the numbers. So getting that qualitative side going. The second thing is really, I call it scaffolding for experimentation. So if we can create a system where people can test things and we can learn the reaction of what those tests are, that gives us a chance to create a platform that others can then use and tie into locally, so we can start to know what's really moving the needle and what isn't. We're in a complex adaptive world, and it's not just easy cause and effect. So by starting to understand that is going to be important. And then finally, the continual integration of local data. So one, if we're doing an annual survey, that makes it really easy to do a chip chop plan that can just integrate that right into the thing without having to do another survey. So can we start to continue to just align things and create more and more understanding to paint pictures of where we need to invest in the vital conditions?
Great. Elaine, what do you see when you look ahead?
Well, the work that we're doing with the community teams is a cyclical process. So we work to develop the community health needs assessment, the CHIP, the action plans, and then we continue to then start all over again, developing the action plan for the next year, and then eventually get back to redoing the CHIPs and creating new ones for subsequent years. So as we go through that process, we continue to pull the data and use it to evaluate our progress and achieving the goals that we've set out in our CHIP. And so we continue to go back to that data and look at it. And then I, of course, pull additional data or conduct additional surveys and focus groups to be able to then inform the next round of that planning process.
Marvelous. Let's see, Jasmine.
So a couple of things too. I'd love to see more organizations in our region integrating the vital conditions into their own reporting, because I think it really helps everybody else understand, how are you contributing to these, and how does that connect with what I'm doing? So the ones that have done it, it's been really helpful. Data sharing, I think, some folks have touched on it already, but I think that's huge. We find often our community can be over surveyed, shall we say, and there's just a huge kind of burden with the surveys. So the more we can kind of share that data across, and also the findings from it, and have a place to do that, I think is going to really help both the community and make community and our own organizations as well. And then I would also love to see maybe alignment around, say, one priority or one vital condition, something that, we're all working towards, but we all have some kind of a role. So maybe it's, it's high school graduation rates, or just something a little bit more specific, but something that's going to have an impact on all these different areas, and have, folks really think about what are you doing in that space? How can we contribute to this? Because I've seen this done really effectively at Seattle, King County, and Washington State. They have really, got on all their government offices to align around a particular priority, and figure out how to do that. In their case, at the time I was there, it was Medi-Cal enrollment, say, but people got so creative across those government agencies around what they could do to help promote that. So,
Marvelous. Sequoia.
So I'd like to echo something that Jason and Elaine both said, because our SHIP and SHA process are cyclical, right? So I'd like to see sectors come together that wouldn't expect to be together, like Department of Transportation and Department of Education, from different vital condition areas, talking about data that they don't think is aligned, but really is, because we all are trying to have positive health outcomes for our citizens in all of our states and all of our areas, right? I'd also like to see us increase belonging and civic muscle, because I think that that's the one that drives all the rest. I think it's why it's at the center, even though I didn't create the model. And I'd like to see, for Delaware anyway, our SHA-SHIP Partnership Coalition, which is made up mostly right now of organizational stakeholders, be filled with just community members who are exercising their voice in what they see, so that we are really literally acting out the Thriving Together theater, so that they're literally deciding with us what our trade-offs will be.
Lovely. Roxanne.
So from a national perspective, I think that when I look to the future, there are several things that I would love to see. We've talked, maybe not on this call here, but about the thriving ethos and the infrastructure that's needed to help the thriving ethos. So it would be wonderful to have things even as simple as the online forums. And I know that sounds dated, but that there's different ways to do things now, where people such as the people on this call can come together and share the ideas on an ongoing basis, not just on a webinar. Infrastructure around maybe completely free for at least the vital conditions nationwide tool would be wonderful, to be able to share on an ongoing basis. And then thirdly, just Bobby and Monty and others can't be at every different place. So what is a curriculum or even just a way of bringing together a set of videos and things to help communities who are just trying to dip their toe into it to get started? So there's a hunger for how do you get started in this work? So that's what I would love to see from a national perspective to help the rest of the country.
That's lovely. And I'll just end from my perspective that there is a frontier of measurement that I think about it in three, sort of three phases. We can measure what's happening with individuals, their well-being, their thriving, struggling, suffering. We could then look at the world around people and say, how well are we establishing vital conditions, doing that equitably, leaving nobody out? And then there's the question about who's stepping into this work. Are we joining with each other, tightening those connections, like building that rising movement of players? And, the colleagues across the National Forum here are an audience of incredibly influential people where the frontiers of this work could rise. And I see one sign already that in the curriculum or the design of the annual conference, which is now in its 20-something year, right? There's increasing attention to these kinds of themes, and just creating space for our dialogue today and the many panels that have gone before is itself a signal of innovating on the things that most matter in this work. So thank you to the National Forum, and thank you to all of you for not just what you've done today, sharing your perspective, but the work you do every day.
Well, thanks right back at you, Bobby Milstein, and all the panel members. My gosh, thank you for sharing such powerful examples of how data-informed approaches can fuel change and create sustainable impact in our communities. I found that this discussion highlighted how essential it is to not only collect and analyze data, but to use it in ways that strengthen the vital conditions for health and well-being. If you have questions for our panel members, please submit them now. We already have some, which is great. I want to note that Sequoia Rent had to depart just a second ago. So her colleague, Dr. Yonda Cuffey, an assistant professor of epidemiology at the University of Delaware, has joined us. So welcome, Dr. Cuffey. You're on mute, by the way. And I'll begin by saying that Roxanne's point about putting data in its place, using data-informed decision-making rather than data-driven, resonated with me, and I'm updating my lexicon accordingly. So thank you, Roxanne. We have, as I said, several questions, the first of which comes from Ray Bridgewater, who asks, as you're using technology in your health outreach, how are you using medical mobile units to physically reach your most vulnerable population, whether it's in a rural, urban, or mountainous region? Elaine, since he said mountainous, let's begin with you.
Well, we are very mountainous here in West Virginia. However, I would say our focus with the community health improvement plans is to go upstream. So we don't necessarily, through the Wild, Wonderful, and Healthy West Virginia program, we don't necessarily provide direct medical services. We look at the policy systems and environmental changes and integrate those into our community health improvement plans. However, I will say there are many groups in West Virginia that are using mobile medical units, and we definitely saw an increase in the number of them being used during COVID, and many of those have continued since the pandemic. So they are very frequently used in our state.
Very good. Does any other panel member have a different experience or a different perspective? All right. Ray, thanks for the question. Elaine, thanks for the answer. That takes us to our next question, which is from Caitlin Hodge, who asks, are you all using these I just said y'all, she said you all. Are you all using these frameworks in place of MAP 2.0 for health assessments and improvement plans, or in combination, using the two together, or taking another approach?
Well, I'll just say by way of context that I remember the earlier generations of MAP when it was really centered around the role of the health department, and MAP itself was an evolution to put the health department into, an ecosystem of other players in the same sandbox. And so the structure of the MAP inquiry was appropriately broad and curious about, what are the forces of change and what are the community assets and so forth. This vital conditions work in some ways is like yet another evolution. I don't think it's a either or. It's about deepening the inquiry about what's going on in this place, what are the assets and current status that we could work with, and it gets even more precise about celebrating those places where progress has been made and securing it, and really concentrating on those places that have room to improve still. So I don't know that there are too many local governmental health departments that have formally integrated the two, but I think this is one of the frontiers. And Jason, the Tri-County assessment happening in Fox Valley is, it's 3 health departments, multiple hospitals doing for them the first time a joint assessment. So it's a good question to those health directors, how does this combine with MAP?
Yeah,
I'd just say in general, it's a great question.
We have 5 public health areas because we have 2 cities,
Okay.
3 counties, and then we have another 4 hospital systems. And we're trying to work on this together. We are using the MAP 2.0 process to do that. I'll call it MAP 2.0 light, only because we're trying to get into a cadence where we're all on the same time frame, which will be a 3-year time frame. But what we've done is from a secondary data collection, we're aligning them all to the vital conditions. So we're looking at all of our information in the vital conditions framework. We are also taking the primary data collection side of doing some well-being surveys here in the next couple months to kind of at least get an understanding of where we are since the last time we took a survey, just in our 19 communities, not in all 3 counties. So we're using both of those as part of our process of collecting information so that we can do a data walk that'll then drive the improvement plan.
And I can jump in here as well from the Delaware State Health Improvement Plan that we've been working on over the past year. We started as Sequoia said with the SHA. Now we've evolved into working on the SHIP. And as we thought about MAP 2.0 and we thought about the vital conditions, we heavily use the vital condition as a guiding framework for our SHA. And we've continued that into our State Health Improvement Plan. And so we've actually have a section in our SHIP where we actually talk about the similarities and the overlap between MAP and the vital conditions and how we're using both of them as a guiding framework for what we're doing across the state.
All right, thanks. Anybody else? Well, this next question, wow, it really goes to the heart of one of the real challenges that I think all of us who work in public health and in population health improvement face as a big practical question. It's posed by Justin Wong, and he says the concept of determining which communities need the support first ties back to the notion that contributing to this work only makes the pie richer. I've always loved that sentiment, but I think part of what fuels the zero-sum game mentality is the amount of funding that exists for different initiatives. I'm sure this rings true for any organization looking for funds to implement different aspects of their work. That is to say, if we don't get this funding, then it legitimately restricts what we can do. Have there been efforts to look at how funding sources or entities contribute to the creation of the silos that separate out the different social determinants? Or really, if calls for applications were framed around vital conditions, would that yield more applications that engage more cross-cutting community building solutions? I'd like to begin with Roxanne, given your sort of macro level perspective, and then see what other perspectives different panel members have.
Yeah, to take in. So I would think that well, sorry, I'm trying to formulate what I would think would be helpful. I think that there is more definitely around the vital conditions. I think people would be able to see more of the multi-solving possibilities. I do think that there are things within the thriving ethos, such as multi-solving, vital conditions, and the stewardship concepts that are very important to maybe yield more cross-cutting community building solutions. I think that there are, and I thought I heard on some of the panels of trying to have funding sources tied. I think, Jasmine, you talked specifically about some of the grants being made, being tied to the vital conditions. But so I'm thinking about it more from a national, but also broader than just the vital conditions, but a lot of what else goes into the ethos of thriving. I don't know if that was helpful.
I'm happy to jump in too. I think that, I would say that we're early in our journey. Our region is early in the journey. We do have, one of the large grant making organizations in our region is fully on board with the vital conditions. So I see, there's going to be some shifts. I think more of us are starting to think like that too. And there is something really beautiful that happens when it's not just a request for how to address one of them, right? But really to think about the multi-solver and thinking about who else can you partner with, I think is always a really important question for that, to make sure that folks are thinking outside of their sector too, because that's where I think a lot of the magic can happen, is when we sort of break down some of those silos as well.
All right. Yeah, Jason.
Yeah, just yesterday, I was working with our local Goodwill on behalf of one of our foundations to talk about looking at a geographic perspective of addressing, in our case, basic needs or poverty. We went through our metrics. We found a specific census tract that we wanted to focus on, and then we went through our 100 metrics across all the vital conditions to start to look at what is significantly changing in this one census tract as compared to the rest of the area. We ended up getting down to, besides the core poverty rates that were going up in this one census tract, we saw our vulnerability index became one of the really key areas that could show this difference, and it wasn't just driven by the poverty numbers because it's an index. And so we're digging in, and we see that in this case, that in 5 years, this area went from like a 17% vulnerability to a 70%. And in 2 years, it went from 30 to 70. So what's interesting is that we can see in 2 years how a metric may change significantly. We're going to do more investigation with lived experience and so on to dig into that. But it was interesting that we went through all the different areas to start saying, this is not a transportation problem. This is not just a work and wealth problem, but that we could see across there many different variables that are changing in a very specific community. And so we're planning to do an investment in that community more as a multi-solver investment, not as a point in place investment.
Yeah, I'll just add really quickly. I put two responses to this question in the Q&A. overcoming the default mindsets about how resources flow is one of the biggest challenges, but it's also one of the biggest opportunities. And what we found is that it really helps when the full well-being portfolio is built at a regional level. So every organization is typically used to the things that they put money out into the world to do, but rarely does anybody ask, how do all of the resources that touch a given population or a given community, a place, how does that add up into the net investments in a region? So we use the well-being portfolio as literally a way of aggregating together the assets that are touching a defined population, and then gather the people who hold the purse strings around those assets to ask, okay, what you're investing in, but the net result, is this what we want together as, for the prospects of this community? And over again, when we do these portfolio negotiations locally, people begin to recognize that, everybody funding their piece is not adding up into even a plausible agenda for system change. It's really a way of squandering a lot of resources into small, discrete programs and projects, rather than investing and reinvesting in a strategic, kind of path toward a different future. It doesn't take very much for people to discover that. And we've seen real progress in very quick amount of time, where people start making different kinds of funding agreements around this work. And so I put in links to some of what we're seeing by people who do that work.
And Bobby, what role does data play in changing that dynamic that you just described?
Yeah, I mean, it's twofold. One is, it's really important that people understand and have a common sort of view of the life experiences of people in the population. Where are we, on a scale from the, sort of fully established vital conditions to none at all, right? How do those vary? So real information about the current state of the world. The aspirations are obviously established very high. And so then the question is, how should we be investing? And that's, people run into a big vacuum because it's not clear we're tracking investment information together. You really need to start, sharing a different kind of dialogue with other people who are making investments. And the abundance of what those assets are is often invisible to a lot of people because they're only looking at their own contribution. The minute you start aggregating it at a population level, what is invisible about the investment flows starts to become more visible and even modifiable. And that's where you start to see, real assets flowing into efforts around belonging civic muscle.
All right. Very important question. So much depends on resources. Steve Sidney, the chief scientific advisor for the National Forum, asks a question about how do you integrate vital conditions with conventional measures of cardiovascular health, such as life's essential 8. So looking, for example, at physical activity, smoking status, sleep status, some of those factors that are risk factors for poor cardiovascular health. I'm pretty sure I know one word that's going to come up here quickly, but I'll hold it to see.
Yeah, and I'm wondering if you might want to start the conversation around this one. I know you think about this interface a lot.
I do. Thank you so much for tipping that to me, Bobby. So a part of our work, as we think about our work with the Delaware SHIP, we have created our objectives, so our overall goals and things that we'd like to achieve across the state. So really, how are we going to advance health and wellness across the state of Delaware? And we have a number of goals and objectives that we're focused on. And so while we didn't formally link that to the simple 8, we do cover each of those things. We think about reductions in tobacco and nicotine. We are looking at blood pressure. We're looking at HbA1c levels as well. And we're also looking at things like how do we engage our community in healthy sleep behaviors, but also in physical activity. And so as we have these milestones, we're working with our community members, our coalition members. We're talking to them about the initiatives that are already taking place across the state, but where there might be areas of opportunity that we can build from. With working with DPH and working with the University of Delaware, are there other ways that we can continue to advance the Simple 8 across our state as well, and factor in these very important health factors for improving cardiovascular disease in our community.
Very good. Does anybody have anything to add?
I mean, just one little simple thing, which is a measure like, tobacco use can be treated as an individual risk factor, or it can be treated as a sign about the extent to which we have, as a society, set up a condition where people can be free from addiction. And so, you can look at the social history of tobacco to see, it was actively promoted and then it became recognized as a lethal threat. The norm started to change, and we are still yet to accomplish the ambition of becoming a smoke-free society. And we're paying a heavy toll because of that. So, it really depends on your interpretation. And Jason, I think you talked about the metrics, like heart disease risk factor metrics are in your Fox Valley Data Exchange. The question is, how are people interpreting those metrics as a mandate to change structural conditions and exposure to risk, versus are they interpreted as, oh, somebody needs, a smoking cessation quit class or something? Those are two different responses to the exact same data.
And we've been thinking and starting to discern around, like, I guess this concept of it's not exactly leading and lagging indicators, but kind of driving indicators, where one is an indication of something else, is an indication of something else. And so we're just starting to get into that space, and we are currently put everything under the vital conditions, but we're actually going to add another little area for, I guess, non-vital conditions, but important information around our community.
So as long as we're getting creative about this, right? If you're looking at one of those risk factors, whatever one they are, let's just take tobacco for the moment. The tobacco rate should prompt us very quickly to ask, how much are we spending on comprehensive tobacco control in our community? The CDC publishes benchmarks for investment, and I don't know that linkage is nearly as frequently as it ought to be.
Well, thank you, Jason and Bobby. Those will have to be the last words. We have reached the end of our time for Q&A. Jasmine, Elaine, Yanda, Roxanne, Jason, thank you all very much. Terrific panel. I think a lot of people, including me, gained a lot of insight into how to make more valuable use of data, and how to have data inform good decisions as we seek to strengthen the vital conditions. So thank you all very much. The National Forum is grateful for your contributions today and appreciates the work that you're doing.